Hi class, welcome to week 7. Today we're going to talk about the genetics of heart disease and Alzheimer's. There is no specific chapter for you to read this week. There are 2 videos located in the content section of week 6, as well as a nice couple handouts related to familial hypercholesterolemia. It would be helpful if you print out the PowerPoints and the handouts that are in there. You will see these 2 topics will appear on the final. So we know that it is a multifactorial diseases, both of these. So what does that really tell us, multifactorial? Well, when we get genetic testing, it tells us our genetic predisposition, or another term that can be used as our susceptibility to disease development. So we know that also there are other factors that influence the timing, which is the age or the onset of the symptoms and the severity. How strong will this disease present itself? And when we talk about these specific diseases, it will make sense what I'm talking about in terms of severity of gene expression. Some of us may have a genetic predisposition to hyperlipidemia or hypercholesteremia, and ours may be less severe in its expression than somebody else who carries a similar mutation. And that can be related to, in our environment, maybe we're healthier, we exercise more, our diet is different. And so both our environment and the genes will express themselves. So we don't really know how well these all play together. We know that they impact each other, and we know that it's very individualized to the patient. And so we do a lot of disease prevention when we look at both just a family history, when we ask our patient, do they have a history of heart disease? Do they have a history of hyperlipidemia? Do they have a history of Alzheimer's or cancer? So what we're looking at is there a pattern in their family? And then we look at modifying some of their environmental factors so that we may get a less severe expression of the disease. There's always research going on in both of these areas, and really what we're looking to do is to control both. How can we better control the environment, and how better can we understand the genes, and what does that tell us, so that we can have better, healthier outcomes. So as healthcare professionals, our job, we do our best to try to influence that outcome. That's where we talk about things such as the DASH diet, increasing our exercise, doing mind games to stimulate the mind, asking people, maybe we're seeing aluminum might play an influence on Alzheimer's, so perhaps staying away from aluminum cans in which our soda comes in, those types of things, if we know people are at a higher risk of developing these disease processes. So the first one we're going to look at is familial hypercholesterolemia. So basically what this means is that there is a defect within the low density lipoproteins, or what we call the LDL receptors, which are located on our cells. So what does this mean to us? Well, as you can see by the slide, if we have this defect with our LDLs, we can see a patient who might have an abnormally elevated cholesterol level, perhaps a elevated triglyceride, or they may have both of those elevated, or we may just see a mismatch in the HDLs to LDLs. And as we know from our nursing education and our nursing experience, that the higher the level of LDLs and our elevated cholesterols, that this leads to the development of the atherosclerotic plaque, which we see in our coronary blood vessels. And with these plaques, we get decreased blood flow, and it leads to the risk of both myocardial infarction and perhaps later on down the road, the development of left ventricular hypertrophy or some congestive heart failure. So familial hypercholesterolemia, or FH, is what we call an autosomal dominant trait. So what that means is that it only requires one abnormality for an individual to be at a higher susceptibility. So it's inherited. So parents can carry an altered gene, and this causes the condition in one in two or 50% chance that you'll pass that on to your children. Terms to remember is homozygote, which means that the person carries both alterated genes in their genetic makeup. And this is very, very infrequent. About 1 in a million people have this. And so they're going to see the development of heart disease in childhood, early teens. And these people don't live very long because of the development of their heart disease and the inability to control their cholesterol levels. And often you don't see many of them beyond 40. These are the people you see with cholesterol levels in the 600 to 1200 range. Then we have the heterozygote person, and this person only carries one of the altered genes. And remember, in an autosomal dominant condition, it only requires one altered gene in order to have the abnormality. So these are more frequent, and these are about 1 in 500. These people tend to have a milder form of heart disease or familial hypercholesterolemia, and their cholesterols are going to range in the 250 to 500 range untreated. And why is this important to know? We'll get to that in just a minute. So familial hypercholesterolemia has some classifications, and it's based on the defect. So a class 1, there's a defective, the defect is within the protein that is produced. In class 2, the protein itself doesn't move from the endoplasmic reticulum into the gloglial apparatus. So the protein it's a defective protein. And then not only now do you have this defective protein, but the protein can't do its job. It can't move. And then if you have a class 3, this is the receptor. Okay, so the receptor is unable to bind with the LDL correctly. And if we don't bind well with the LDL correctly, then we can't move the cholesterol out of the blood stream itself and into the cell. And that would be a class 4. So the protein, it can get to the cell surface, it binds with the LDL, but in this defect, it can't complete its process of endocytosis, which is to get rid of the cholesterol. So why is it important to know if someone is heterozygote or homozygote? As you can see by this slide, and it's kind of an important slide to remember, is that the heterozygote can benefit from pharmacological therapy. So we can use statins or resin binding agents to help lower their cholesterol, and we can do a good job of getting them to within a normal range. We also have to modify their diet, increase their exercise, and those types of things. But medication can really help lower their lipid panels. Where with the homozygote, medication is going to be pretty much ineffective. And these people have to have what's called therapeutic apheresis. This is when their blood is put through a special process and the cholesterol and the fats are actually removed, and then the blood is returned back to the body. So when we look at pharmacology, what is the goal of pharmacology? Well, the basic goal is that we want to reduce the cholesterol levels, because it is that elevated cholesterol that leads to the formation of the fatty plaques. And the plaques lead to the atherosclerosis disease, which leads to the development of the clot, which then puts the patient at risk for myocardial infarction. So we know that we can do that pharmacologically with our heterozygote patient with familial hypercholesterolemia. And we can, we want to divert an increased fraction of the cholesterol to the biosynthesis. We want to use those LDL receptor genes. We want to stimulate them to produce more hepatic receptors to clear out more cholesterol. And we want to help the LDL bound cholesterol to bind the cholesterol, which can help reduce our plasma cholesterol. So we're all familiar with statin medications. In a sense, what do? They help inhibit synthesis of cholesterol by the liver because, as we learned in anatomy and physiology, and is that our liver actually can produce cholesterol all on itself. And we want to suppress that cholesterol synthesis by the liver. Sorry, I forgot the R there. That live is supposed to be liver. It's used in the patient with the FH to reduce the cholesterol levels. And if we use statin medications, we can decrease their cholesterol levels and help see a decrease in the LDLs by about 40 to 60% in most patients. And this is not unlike the patient who doesn't have FH but just has hyperlipidemia. We use statins to do the same result. I'm just pointing out here that with your heterozygote person that has FH, this is how the medications are going to be helped, and this is how you're going to see them be treated. We also have non-absorbable resins. This might be your questran or cholestid. And what this is going to do is it's going to bind bile acids in our intestines. And it's going to prevent recirculation by the liver. And so what happens is we have an increase of fecal excretion of our cholesterol. You can see they have some side effects. And alone, non-absorbable resins can reduce your cholesterol by about 15 to 20%. They're not first-line drugs, but in combination or with people who cannot tolerate statins, they do provide some decrease in the cholesterol and help lower those circulating lipids in the bloodstream. Like I said, the statins are more effective, and you even get more effect when you use them with the bile acid resins because they both work in a different fashion. So you get this increased effect of being able to lower the cholesterol. So we also know with statins, there's often, there are side effects which prevent people from wanting to use them. A lot of people don't like the diarrhea or the constipation, muscle aches and weaknesses, joint pain people don't like that either, and they'll go off their statins. The other thing about statins is we need to watch their liver enzymes because of how they work in the liver. And so most patients will have a baseline set of liver enzymes done, and then about every 6 months they'll be monitored to see if there are any increase in those. Also, genetically, you can have the development of arrhythmias. Research is showing us that there is some genetic component to some of our arrhythmias that we see. And what they're finding is that it's connected to genes that code for specific ion channels that help regulate our heart rhythm. The term channelopathies is termed for this discovery. And a couple that they're seeing that there's a genetic link to is atrial fibrillation and long QT syndrome. So long QT syndrome, what is it? Well, we see a delay in the repolarization within the cardiac cycle. 1 in about 2,000 people are diagnosed with long QT syndrome. And when we say someone has long QT syndrome, we're looking at the QTC measurement, and that's what we measure. And what that is that's our QT interval, looking at and taking into effect our heart rate at the time. And that's measured in milliseconds. And as you can see, there's a different standard used for both men and women. So what is the treatment for long QT syndrome? For some people, it can be as simple as being placed on a beta blocker. For many, they might have a pacemaker or an AICD device implanted. So then we have familial hypertrophic cardiomyopathy. This can be termed HMC. You'll see this in about 1 in 500 adults. Its pattern of presentation is autosomal dominant. So as we remember from our last familial hypercholesterolemia, that means that it only requires one abnormality in order to show susceptibility or some aspect of the trait. So what happens in this is that we see this heart muscle, our heart muscle thickens, and generally you see it asymmetrically. So one side of the heart may be thicker than the other. And this gives the patients problems with ventricular filling, as well as you might see some diastolic dysfunction. There are also oftentimes issues with the outflow tract of the blood flow. And how do we know somebody has left ventricular this familial hypertrophic cardiomyopathy? Generally, you see a patient who has left ventricular hypertrophy, but they have no other cause that might be a reason for the development of left ventricular hypertrophy. What this means is they probably had no history of an MI. They have no history of, say, aortic stenosis or hypertension. What you see is that they have left ventricular hypertrophy and no other reason why they should have it. And now we're going to look briefly at Alzheimer's disease. 1 in about 4% of people develop this in developed countries. It is responsible for about 100 deaths per year. Generally, most people who develop Alzheimer's begin to see an onset of symptoms in the 70s to the 80s. But it can present as early as in their 30s. So what are some signs and symptoms? We'll see memory loss, deterioration of higher cognitive functions, and you'll see behavioral changes. And why do we see that? Due to there's a degeneration of neurons within our cerebral cortex, the temporal parietal cortex, and within the hippocampus. And this disease, just like any heart disease, is related to environmental factors and onset of symptoms and connected to family history. But as we know, there are people who have no history of Alzheimer's and they will develop it anyway. Genetic testing will tell someone if they're more susceptible to the possibility of developing Alzheimer's disease. So there's a general pathological abnormality. There is a disposition within the brain of fibrillary proteins, a beta amyloid peptide and a tau protein. And this is, they are deposited in the brain and they cause this pathological change. Research has shown that there are many genes that encode for these proteins. And the protein that leads to the neurofibrillary tangles, which contribute to the Alzheimer's disease. And there are other genes that are related to the development of Alzheimer's that are important as well. This disease has multiple contributory things that they're finding that lead to the development. So a person could have a mutation that might just be an altered encoding of the protein. And someone may have a gene that relates to another protein, and they could each develop Alzheimer's in their future. So there is what is called early onset. And most early onset Alzheimer's is related to familial Alzheimer's disease. And this is a type of Alzheimer's that occurs between the ages of about 30 and 60. It's rare. It only encompasses about 5% of the total population of people who are diagnosed with Alzheimer's disease. They want us to know in this particular thing there is a single gene mutation, and that can happen on chromosomes 21, 14, and 1. One person might only have a mutation on 21. Someone might have 21 and 14. And someone may have the mutation located on all 3. So if you have these mutations, what happens within your proteins is that you create an abnormal protein. And so if you have the mutation on gene 21, as you can see, there is an abnormal formation of your amyloid precursor protein, or APP. If you end up with the mutation on chromosome 14, that you have an abnormality of a different protein, as well as with chromosome 1, as you can see for yourself. So why is this important? Because the mutations play a role in the breakdown of the APP. And it's within this breakdown process that, that there is the generation of the amyloid plaques. And amyloid plaques, as we've heard, within much of what we've learned about Alzheimer's is what they see on autopsy in the brains of those who have had Alzheimer's at the time of death. Know that familial Alzheimer's is autosomal dominant. So think back to whether we have someone who is heterozygote or homozygote, then we would know that the homozygote person who inherited both mutations would have a much more severe and perhaps earlier onset and a stronger disease presentation than somebody who only had one, received it from just one parent. That's where the homozygote and the heterozygote presentation that genetics can tell us is there. So then we have the late onset Alzheimer's. This develops after the age of 60. We don't really fully understand this particular disease process or its causes. This is one that genetics and environment play a huge role in, and our lifestyle plays a role. That's why they're encouraging the elderly now to stay active, to be thinking, to be doing things that challenge their brain, to be stimulated, in the hopes of decreasing the severity of the memory loss that goes along with it, and to delay the onset. As I talked about in early Alzheimer's, there is a single gene mutation, but for late onset Alzheimer's, they're not sure what's responsible for the cause. They've been unable to particularly locate a specific abnormality. They do know that there is a genetic risk linked to it, so you see it in families. They do believe the risk is related to the amyloidoprotein E gene, and they know that that's found on chromosome 18. So what does this gene tell us? Well, it carries the instructions for making proteins. So perhaps if we don't make our proteins correctly, then we'll lead to the development of these plaques as well in this disease. So I've kind of broken down for you the type of APO genes and kind of what they do and where they look in Alzheimer's disease. This particular slide you will not have to memorize or know. It's just really for you to see that there are multiple possibilities for why a person might develop Alzheimer's. They may have an abnormality in one of these particulars, or they may have an abnormality in two or even all three. And as you can see, the more abnormalities you have, the stronger your presentation, the more severe your symptoms. And so it helps us to understand why there are varying severities of diseases. So how can we help with Alzheimer's disease? Well, we can use cholinergic drugs. We also know that they're parasympathomimetic, and they help decrease the symptoms. They really aren't going to change they aren't going to change the disease process itself, but they help us really manage the symptoms and help the families and the patient not feel so lost. We've heard of Aricept, usually given at night. Unfortunately, this can cause insomnia. And it's used to increase the acetylcholine levels. And that's the end of our show, and I hope you guys all have a great week. Just a quick FYI, please remember that next week is midterm week, and I'm available to any of you by email if you have any questions about the midterm. I hope you all have a great week. Thanks.